things that were either asked over the weekend or like on the break last time, things like those I kind of want to address. So before we were talking about looking at actually this hip x-ray and the AP versus the PA, right? Something I didn't really kind of clarify for you guys before is that the majority of x-rays are going to be shot AP. That's just the standard kind of how they'll do it. They'll be shot from going anterior to posterior. There's a couple that are PA, like the wrist, is just easier to lay the wrist like this, the chest, things like that. But what I wanted to share is that regardless of how it is shot, because it's kind of like the, we talked about the dislocations, right? We had to find a way to describe it so we all talk the same language of why they name a dislocation that way. Same thing with this, regardless of how these pictures are shot, regardless of the PA, AP, anything along those lines, they are still always going to flip those images so that your right is their left and your left is their right, because that is the standard. That is the standard expectation across medicine, okay? Honestly, a radiologist would not even accept it if they did it the other way. Before it even get to you, they would look at it and be like, no, flip it around and do it the right way, because that's the way they're trained to read it and look at it as well. But almost all of your x-rays, I think outside of, trying to think about it right now, outside of hand and wrist, which they do a PA just because it's easier just to lay the hands flat on the film, and chest, pretty much everybody, those frontal views are AP. Femur, knee, tib fin, shoulder, spines, all of that is going to be AP and a lateral, just so you guys are thinking from a position standpoint. So that was one of the questions that I kind of had that I wanted to clarify. And then the other one was talking about the ultrasound, right? What's Doppler versus the duplex, the quantitative flow, right? You can get pretty deep with this when you add the two together, right? With the Doppler and the quantitative, you can add those together. Sometimes you can check the velocity of the blood going through the vessel and stuff. Listen, stay in the lily pads for this, okay? What I need you guys to understand is Doppler ultrasound is what is used to assess blood flow to and from a particular area like a testicle or an ovary. I'm using that Doppler to make sure blood is going to and from, okay? So like an organ like that. Your duplex ultrasonography is specifically used for vasculature, looking for blood clots, a DVT or something along those lines. Duplex is vasculature. Doppler, yes, you can add it to the vasculature, right? But duplex does not work for the blood flow to the organs, right? And that's really your distinguishing point. Is yes, you can add Doppler to the duplex and kind of make it, use the vessels and look at it a little bit more, but you can't use duplex in the testicles and the ovaries to evaluate for the blood flow. Does that clarify that just a little bit? All right, so just, I want you guys to stay on the lily pad, stay on the surface of knowing what Doppler is used for, what duplex ultrasound is used for, and don't get any deeper than that. The book can get a little bit deeper and kind of go into the weeds, and that's why I pulled out just the basics and threw in the slides for you guys. Other than that, any other questions over the material so far?
So
Yeah.
you said you were going to talk over this one about how it's shot, like how you said you know this is a right.
Yeah. So anything besides that one. Okay. So now again, that's going to go back to what I kind of just said before, right? How do I know it's a right? Well, this is an AP hip X-ray, or really tight upper part of the femur, right? And when I'm looking at it, and I have to use this because my screen is broken, so I can't draw on it. When I'm looking at the hip and the pelvis area, in my mind's eye, if I continue to draw this, let's say this was a puzzle, and you were putting a puzzle together, and you had put together this piece of the puzzle, and you started to get more pelvis pieces of the puzzle. You know, based off of the direction this is, and looking at soft tissue air, that my pelvis pieces are all gonna go all over here. So now I can imagine another leg being here and the rest of the pelvis. The rest of the pelvis and another leg. So now, if I look at it as if pretending the whole pelvis is there, my left is the patient's right. My right is the one that's missing, that's the patient's left. So that's how I know this is a right femur and a right hip, because I have the context clues of my pubic rami, my ischium coming down here, the femoral head going into medially the way the pelvis is set up. if I had just the lower part of the femur here, and for whatever reason this pelvis was cut off, and I didn't see the femur, I just had the lower part, I have no way of knowing if that's right or left. I need that pelvis, part of it, and that femoral head and acetabulum for that context clue. Same with the shoulder, when we look at shoulder x-rays. Where is the humeral head going in? Where is the scapula? Is it on the outer portion? What side is it on? Because we can use the thorax as that context clue to be able to put together right versus left. Did that make it more clear?
Did certainly.
Okay. Everybody good on that? It can get confusing, I know, that's why we're gonna spend a little bit of time on it. Feel free to ask me again, I'll try to put it in different words if I need to, because this stuff is abstract. You gotta try to find a way to kind of wrap your mind around it. Alright, so back to describing fractures. Transverse is straight across. Transverse is straight across, okay? Oblique is what it says. It's at an angle, diagonal, oblique, okay? The trickiest part of finding the directions of fractures is how do I distinguish between the oblique and the spiral, okay? There are two ways to do it. One of them is the mechanism of injury. If I tell you a patient had a rotational force, right there, rotational force, okay? Be thinking spiral. If I tell you that they stepped in a hole and twisted and then got hit while they were twisted, or the little old lady who fell down the stairs and caught her arm in the railing as she fell, right? Things that cause a rotational force, you start to think spiral fracture. What this is as they fell, the bone twisted as it broke, right? So it's causing a spiral fracture. Another way you can tell is when you have that rotational force injury, look at my oblique and my transverse compared to my spiral. Look at how, again, it is a 2D picture, but look at how it looks like the bone and the fracture has depth to it. Looks like there's layers to that fracture. You can kind of visualize how it twisted and broke off with these two different density layers on these views right here. That's what makes it a spiral. It's not that clean oblique fracture, right? I have different depths. Here it broke here, but then it broke in a different area of the femur up in there, and I have those layering levels. Everybody see that? Okay, so that's clue 1, and clue 2 is mechanism of injury. In your vignette, sometimes you're trying to decide between oblique and spiral, and you're not 100% sure, because I mean this fracture right there, it's kind of oblique, right? It's kind of diagonal, but it's got that extra element of the spiral. Go back to your vignette. If it's subtle, go back to your vignette. What is your mechanism of injury? If it's a rotational mechanism of injury, lean towards spiral as opposed to oblique. Okay? Alright, other fractures. Clavicle, we talked about this, right? We named the displacement based off of the distal segment. Distal segment. So, this here is 3 pieces, so it's a comminuted fracture, right? And so I would name this as inferior displacement. Right? The bone is not lined up the way it's supposed to be. It's been displaced which way? Inferiorly, because the distal segment is lower than the proximal segment. That makes it an inferior displacement. Don't get so hung up on the middle picture. We used to do things like angulation 30 degrees. In some places you may still hear that. But honestly, we don't want you to measure anymore. When you're talking to ortho, they care about apex. When something is angulated like that, just tell them which way is the arrow pointing. So apex superior. If I were to draw a line there like an arrow, draw a line down here, the arrow is pointing superiorly. So we just name that apex superior. So this would be like a mid-shaft, left clavicle fracture, apex superior. That's how I would describe that. You can add simple in there if you want. You can add transverse because it looks like it's kind of straight across, right? But some of these words you can use to describe, you don't have to use them all. If you just use enough to paint the picture. If you were to tell me I have a simple mid-shaft clavicle, left clavicle fracture, apex superior, I already know what I'm looking at. Follow? Yes? Hopefully. Gosh. Feedback.
Sir, does this count
Yes.
for like, say in the leg, we have it angling out,
Yeah.
say apex lateral, apex medial, or the
Bingo.
same thing?
Yep. Yeah, counts for any bone that's doing that. Again, mostly simple fractures, right? Because if it's comminuted, I mean, I may have an apex there, but really the common is the more concerning thing, it's in a bunch of pieces. But yes, this can happen in the tibia, the fibula, the forearm. Which way is that pointing? You can use that for any of those bones, yep. Okay, another one, shortening. Are the bones overlapping one another? Now, this is more often than not what's gonna happen in some of these major bones, right? Because we have muscles that connect to the bone via the tendons, and that's what keeps them apart. When they fracture, they shorten. Now, you could do one of two things here. You could say shortened, right? Or I could also say displaced superior and medially. You see where I'm getting those words from? If I wanted to say that, instead of saying shortening is just an easier way to say it, but I could also say it's displaced medially and superiorly, because the distal fragment is shifted medially and shifted up. Either one will describe it. So what does that mean? Well, on a test, if I want you to describe this, I could give you shortening as the right answer, or I could give you displaced medially and superiorly as the right answer. I can't give you both, because then that makes two right answers. Sorry. Overriding could be another term that could be used, yes. I will tell you in the world of radiology and ortho, they usually use shortening as opposed to overriding, because my thing is with this, is it really truly overriding, right? The true definition of overriding would be literally like right on top of one another, kind of sitting like this. I can't really tell here if it's actually overriding the other piece, but it's a descriptive enough term that most people in the medical field will understand what you're saying. We just don't typically use it in the radiology world very much. Shortening is usually what we go off of. And I'd be okay with that word. Okay, that's enough, that's all right.
It's just saying things four different, like saying the same thing 3 or 4 different ways. It's always frustrating.
It is. So and that's why I quantify it with shortening is typically the verbiage that is used. Yes?
If the picture on the right, why would you not say that's like laterally superior?
So here, you can, but, and we haven't gotten to that one yet, but I'll do it right now. So you absolutely can say that this is displaced laterally and superiorly. I'm okay with that. Here's the problem. In this case, it doesn't fully describe what's going on with that fracture, because it's also rotated 90 degrees down here. What you have here, and you'll see this more when we get to the lower extremity of what they look like, you have an AP tib fib shot with a lateral ankle, which means that lower part of the tib fib and the ankle is rotated 90 degrees. So if you were to just give me shortening or just give me lateral superior displacement, you're not painting the full picture, because that's rotated 90 degrees. Does everybody see that? So that's where rotation would come into play in describing this one. Yes, sir?
So then we call it like transverse medial rotation linear.
So probably lateral rotation, because it's pointed out towards the lateral side. But I could do it, I would want the other picture, but I could see where you would get away with transverse fractures of the tibia fibula with lateral rotation 90 degrees. Again, we're aiming which way it's pointing, not right, so it's out this way. But
I didn't catch the.
that's okay. But the concept, I'm okay with that. If you're talking to me on the phone and you use those words, I'm like, hey, I got a transverse fracture of the tibia and fibula, complete transverse fracture with 90-degree lateral rotation of the foot and ankle. I can paint that picture in my head, so I'm good with that. Questions? Okay. But open fracture versus closed fracture, we kind of belabored this already. So the biggest thing is if there's any open wound period along that fracture to the outside world, there's open fracture. I don't care why, I don't care how, I don't care if it was a gunshot with shrapnel, I don't care if they fell on the ground, they broke their bone, the bone is still kind of like a subtle break, and there's just scrape from road rash. That's an open fracture. That's an open fracture, because I have a fracture, and over it, I have a wound, that skin is open to the outside world, we treat it like an open fracture. Because you weren't there when the injury happened, you don't know if that bone came out, went back in, and frankly, it doesn't really matter, because if I've broken the skin, bacteria has a way in, and can now work its way down and get to that fracture in the bone if it needs to, or if it decides it wants to. And if you don't put on antibiotics, you run the risk of osteomyelitis or septic arthritis or something along those lines. Okay, so knowing that, we've already covered the forearm one, you guys know the answer to that one based off of the soft tissue. But what about this first one, open or closed fracture? You haven't seen the patient yet. Bingo. It is an open fracture. The bones are sitting outside the soft tissue. Right there. So yes, you can determine open versus closed based off of x-ray alone in some cases. This one we covered as a soft tissue little notch. That gives us that clue on that one.
That one would still be considered open.
Still open, because even though the bone went back in place, it exposed to the outside world. The wound is exposed to the outside world. It is still an open fracture. Sir?
For the one we determined with the X-ray with that little piece right there.
Yeah.
Do you also click and correlate by like, if you see that, do you like see if you can run sterile swab up there to see if it goes to the length of the bone? I've seen providers do that. in the past.
Yeah, not really, because, I mean, could you, sure, do you need to? I mean, I guess if for some reason, right, the only way I could think that that would be 100% necessary would be if for some reason this patient has been on like recent multiple bouts of antibiotics, and you're really concerned, like, do they really need these antibiotics, right? I don't know if I wanna let me make sure, and then maybe, but even then with the risk, I'd probably just get the antibiotic, yeah. That's the only reason I can think of doing that. Okay, buckle in. Salter-Harris fractures. You will see this again in ortho. Promise you, you will see it again in pediatrics. I have it flipped upside down for one main reason. Which way is the x-ray gonna be presented? Like this, right? Is the joint down here? Because if it's the bottom part of my femur, it's gonna be like picture 1. If it's the top part of my tibia, it's gonna be like picture 2. But they're still the same, right? It just depends what bone it is and where the issue is. Salter-Harris fractures are fractures of the physes, which means it can only be in what population? Pediatrics. Pediatrics. We will go over how to break these down, but Salter is broken down into 5 categories. Type 1, S, for Salter, is slipped. That's where the fracture is just through the physes. I'm going to tell you right now. Type 1 and type 5s are hard to see. Type 5s are almost impossible to see on x-ray unless you're a pediatric radiologist. Which means, if you're having a test question, type 5s are almost impossible to see unless you're a pediatric radiologist. Probably not going to ask you to pull out a type 5. But boy, there's 5 Salter-Harris types, so what an easy 5 answers I could have for an x-ray or 2 to try to pinpoint these things, right? Probably not gonna give you a 5. So S is slipped. So what that is basically where you have the metaphysis, the epiphysis, the physes is in between, and it slips off one end. Doesn't have to all the way slip, it can slip off just a little bit. It's where the fracture goes through the physes and it's slipped. S is for slipped. Okay? Type 2, through the physes and through the metaphysis, or A for Salter as away. I do away from the joint, because if you do above, and then you look over here on picture 2, that could be confusing. Some people use A for above for Salter-Harris, but if it's flipped, that could be confusing. So I do away from the joint, A for away from the joint. Yes, sir?
Can you repeat what you said about, like, your example of which bones would be on each side?
So for example, let's say this is the inferior femur, right? This one would be your superior portion of your tibia. because the bones come in different directions, but they both have physes and epiphysis and metaphysis. We'll see some examples when we go through it. So that's why I have it flipped. So just because the bone is flipped doesn't mean it changes the Salter-Harris classification. So the way I memorize it and learned it from me, I learned metaphysis and epiphysis, and that's how I do it, because no matter which way the bone is flipped, the metaphysis and the epiphysis are in the same spot every time. Right? I know what part of the bone that is. So now I'm gonna play with this away, above, whatever kind of confusing mnemonic the Salter is. But if you use it that way and you learn it that way, S for type 1 is slipped, and we'll look at some pictures of that. A for type 2, I would do away from the joint, right, through the physes and up, away through the metaphysis. Salter-Harris, and that's the most common. Most common is type 2. Salter-Harris 3, L for Salter, through the physes and lower than the physes. I know it's confusing when it goes over here, but that's what the L stands for. So I learn it as type 3, 3 ends with an E, epiphysis starts with an E, so I know type 3 goes through the epiphysis. That's how I remember it. Type 4, T for Salter, T is through. It goes through both the metaphysis, the epiphysis, and these are all included in the physes anyways. So 4 is through. 5, R or ER is for reduced. It's a crush injury. That's what the R is there, reduced. The physes is reduced on itself. Here's another cartoon that kind of shows it and breaks it down. Type 1 doesn't really show it slipping, but we'll look at x-rays where it does show that. But really 2, 3, and 4, which means don't get tripped up. When you find a 2 or a 3, your next step is to go through the x-ray and make sure it's not a 4. Right? Make sure it's only through. If it's a 2, make sure it's only through the metaphysis and the physes. If it's a 3, make sure it's only through the physes and the epiphysis. Because the second it's through both portions, it becomes a type 4. And if there's any mistakes that are made when it comes to Salter-Harris's, is that you guys get excited because you find the 2 or the 3 and you move on and you forget to double check to make sure it's not a 4. Okay? Here's another example based off of an x-ray. I recognize there are lines and not fractures there, but it just kind of shows you what each of the types are, giving it to you in multiple ways to kind of view this. And now we'll talk about it. So, let's start with type 1. Type 1 is that slippage. How do I know it's slipping? Well, I'll go back to type 1, I'll go back to the first picture in a second. Let me look at some of the other pictures. You see how the epiphysis and the metaphysis line up pretty well with one another in all of these photos. Okay? If I were to follow the cortex around and draw it, they line up with one each other pretty nicely in almost all of these guys. The metaphysis and the epiphysis are lining up with one another. But when I look at the first one, I don't have it lined up. The epiphysis, or the radius here, is slipping off. That's your type 1. The fracture is only through the physes. It's hard to see a fracture through the physes because there's already this line sitting here. How do I know it's fractured? Because it's slipping off of where it should. Think of an ice cream scoop kind of slipping off of the cone a little bit. Everybody see that on the first one? Second one, this is where it flips, right? Away from the joint. But really, I just learned it as through the metaphysis. It's going to be a lot easier if you can remember it through the bone, because no matter which way the joint is facing, you know which bone or which portion of the bone the fracture is going through. So I got it through the physes, which I can't see, but then I see the fracture right here through the metaphysis. What else is going on in that x-ray? Ulnar fracture, right? Right here. Borderline is that green sticker, transverse. It looks like it goes all the way through. You can probably see it better on your screen. It's really subtle towards the cortex. But yes, there's also the ulnar fracture. Is this a Salter-Harris fracture?
No.
It's a pediatric, why not? It's not through the physes. Bingo. Pediatrics can have fractures that aren't Salter-Harris if they don't involve the physes. How do I know it involves the physes? Because I have the fracture that goes up and goes right into that joint space there. So it involves the physes right there. Okay. 3, through the physes and down into the epiphysis. Through the physes and into the epiphysis. The yellow line is raised a little bit high so you can see the physes in there and down into the epiphysis. That's your 3. And then 4 is both, and it can be that subtle. The yellow arrow is a fracture of the metaphysis and the fracture in the epiphysis. I had it through, so it's a Salter-Harris 4. And I didn't give you a 5. Because you're not pediatric radiologists. Okay. Questions on Salter-Harris now? We're going to see a few more of these as we go through the lectures. Right? Try to figure out what memorization classification works for you. The reason these are so important is almost all of them are going to require some type of surgical fix, because if you miss a Salter-Harris, you will cause growth issues in that limb for that child, especially depending on what age they are. The younger they are, the more issue we can end up having if we don't catch it on time. So I have a 10-year-old who fell from the top of the playground slide, approximately 10 feet, onto an outstretched arm. Take a look at it. Let's see what we got here. Take a look and try to read your abnormalities. All right, first of all, let's go simple. Which bones are fractured? Radius and ulna. All right, beautiful. Which one is just the simple transverse fracture? Radius. Right there. How else could we describe that? Shortened. I like it. Let's go with the easy terms, right? Shortened. So we got a simple, transverse, shortened radial fracture. You described everything you need to for me for it. Good job. Now let's go to the ulna. Green sick, or what classification is that also? Incomplete, okay. Incomplete. What other word can we use to describe it? Say again? Green sick, yep. What else? Are we simple? Are we common union? What are we? Medium? Maybe? Oh, the medially, yeah, the medial annulation, yep. It's a little bit tricky. We'll go back to simple versus common unit in a minute. What else? What other abnormality can we use to describe this? Does anybody see a Salter-Harris on here? Salter-Harris 1. Here is my epiphysis and my physes that is completely slipped off of the metaphysis. It's off. It's hiding behind the main shaft. That is a Salter-Harris 1. Because this should be up here, or this should be down here, however you want to look at it. It's been completely slipped off. And then if you look closely, it almost looks like that epiphysis Is it in maybe more than one piece? Right, I kinda got like this radiolucent line underneath here, possibly that fracture too, so I'd be okay with comminuted. I'd be okay with the incomplete green stick with the Salter-Harris one, right? This is just going to show you that there can be multiple abnormalities on one x-ray. Just try to paint the picture as best you can. Yes, sir?
Sir, can you point out where it would be on that other image? I just don't see it on the other side. Shouldn't it also be?
It's hiding right behind the radius here. See this extra radio opaque area? That's where it's sitting. Which we can't really see, you can see it there, but again, when I go lateral now, that means it's lined up with that radius laterally, and that's what that extra radio opaque little hump is there behind the metaphysis. It's a harder one, I give you harder ones on the lectures to help you see it, so that way you understand all the little intricacies of kind of what you're looking for, and do that intentionally. Does everybody see now that I kind of described it? Yes, no? Yeah, hopefully. Okay. Some smirks, some head nods. You will within a couple weeks. Alright. So let's do a praxis. I got a 50-year-old female who caught her arm in the rail and rotated on the stairs. When she slipped and missed a step. What best describes a fracture in the image? Okay. Let's first go through. We have 5 choices. The first word on all of them. So what best describes a fracture in the image? Comminuted or simple? Okay. I'm taking a look at this. What do I have? Do I have comminuted or do I have simple?
Simple.
Simple. I only see 2 pieces. Which means I just ruled out 2 answers before I even did anything. I'm down to a 33% chance. Alright, what's the next word? Oblique, distal, proximal. Okay, woof. Distal or proximal. Let's stay away from oblique for right now because that's different. But I have distal and proximal. Right? It's not distal, it's definitely proximal. So I just ruled out Charlie. Now I'm doing the 2 answers and I'm trying to figure out what the heck's going on. Do I have a proximal fracture? Do I have an oblique fracture? Which one is more right? Right? Because I can give you oblique and not tell you the area and it can still be correct as long as the type of fracture on your proximal is incorrect. So now I turn around and go, now I look at the whole answers. Now I'm down to 2. Simple oblique humeral fracture, that is a humerus. Simple proximal spiral humeral fracture. Okay, they're both humerus, so the bone doesn't help me. Great. So now I'm between oblique and spiral. Without the vignette, this is just in yourself, you don't have to raise your hand. Ask yourself, would you have been able to look at this picture and tell me it was a spiral instead of an oblique? Maybe with more practice. I like that answer. Because you can see the depth here in the fracture of the humeral head for the proximal. And I say yes, I can see it. I've looked at thousands of x-rays, right? But there is some depth in there. But me recognizing that you guys are at a level that maybe you won't be able to pull that out right away, I'm giving you the fact that she caught her arm in the rail and rotated down the stairs. So now if I ask you what's the most likely, based off of all the information provided, the answer is going to be echo, the simple proximal spiral humeral fracture. See how I went through that, right? Because in reality, in clinic, you're going to have this information before you sent them off to the x-ray, right? Or the nurse got it when they were in the triage in the ER, and that's why they sent them for the x-ray. So this is an example of some things you may end up seeing. There we go. So, how about one more? 17-year-old male fell on the stairs, sustained a LE is lower extremity injury. But let's skip all that. Based on the image and physical exam, what's the best description of the injury? So I'm not even looking at the vignette. Best description of the injury. I got 2 open and 2 closed. Which one am I dealing with? Open. I just 50%. Fantastic. They're both tib fin. Okay, great. They're both comminuted. Okay, great. Proximal or distal? Distal. I didn't even read the vignette and I got to the answer. Now, I'm not going to answer that yet. I'm going to go back and read the vignette real quick to make sure that there's not something in there that makes me realize that I need to go back and double check my answers, right? Now I go back, 17-year-old male found on the stairs, lower extremity injury, small lacerations, open, so we're there. Medial elastic lower extremity based off of the image, yep. Okay, not proximal, we're good. So the answer is going to be the open distal comminuted tibia fibula fracture. Good. Perfect Salter-Harris question. You just learned it, so I don't know if you don't know it right now, if you didn't study it, that's fine. Don't be sarcastic. Maybe I'm moving 5 on there now. Just for you, just your test. We'll have a Salter-Harris 5. Everybody else will have a 2 1. We can't do that even if we wanted to. Alright, so what Salter-Harris are we thinking?
C.
I'm getting a lot of Charlies. Some are going most common, right? When in doubt, you can always go most common. That would not be a good idea on this one. That would not work well for you. But if you go with the other one in doubt and you just Charlie out, that would work okay. This is a Salter-Harris 1. Unfortunately, I can't label things Charlie because your guys' answers get jumbled, so your Charlie might be somebody's Bravo. Yeah. So, no, it would not be dislocated. I might buy subluxated if you wanted to talk about the epiphysis and the metaphysis. Remember, dislocation means a complete separation from bone to bone over the course of a joint. This is part of the same bone, right? So you're not really going to dislocate these guys. So it's, no, it's not dislocated. Pediatrics can be tough because they're not fully formed yet. So if I give you guys any dislocations, they're going to be extremely obvious or they're going to be adults. Everybody see the one though? See how the ice cream cone is slipping off? Right? Okay. Whew. Alright, let's jump through some healing definitions. Mostly definitions for this. This is the healing process, FYI, you learned this in AUP, therefore you again. Okay. Delayed union. Fractures that take twice as long as expected for a specific location. Every location is a little bit different. You will learn more of that in ortho, but about twice as long as suspected. Your non-union is any fracture healing that has not occurred in 6 to 9 months. Right? There's not many fractures out there that take longer than 6 months to heal. Most of them are like 6 to 8 weeks before things are doing pretty good and you kind of start to get back to activity. But 6 to 9 months is what's called a non-union. Most commonly, your scaphoid, your femoral neck, and your tibial shaft. Those are your 3 most common non-union fractures. Okay? Malunion is a fracture. Sorry.
I apologize, sir. So femoral neck is just because of poor vascular supply.
Correct, same as scaphoid.
And weight bearing.
Yeah.
And the tibial is just because of the constant weight bearing.
So the reasoning, right, the scaphoid bone and the femoral neck both do that vascular supply. Those are the areas where you get that avascular necrosis, right? And so vascular supply can cause a non-union fracture healing process. And the tibial shaft is based off of the fact that that is the area of the body that takes the most direct impact. The weight bearing, the walking, the running, it just very commonly is going to be non-unionized. Yeah. Malunion is a fracture that healed. It's back in one bone, but it's a non-anatomical position. What does that look like? We'll look at it here in a second. So there's your perioscular reaction. Remember we looked at that for those like hairline fractures. You can look at mom and dad and say, yep, they had a fracture, it's healing. Just know that we can see perioscular reactions on x-ray. My cortex ends, right? I got my cortical bone here, and then I have this extra little radio-opaque line. Looks like a little hill just sitting right on top of the cortex. That's a perioscular reaction. Sometimes they're bigger, sometimes they're smaller. Here's a delayed union, right? It's starting to heal together. How would I know that it's going to be twice as long as expected for a specific location? Well, you'll learn about that stuff in another semester. You just need to know this definition that it's a delayed union. Okay? You need time frames in order to do this. Non-union, this is an extreme case of this. How can I know it's a non-union? Well, there's two ways to tell. One, if we had that, like we had that skateboard where it looked like two separate bones and their own cornice around it, it had been a long time after the fracture, and that would be this here. This is I think this one was 9.5 months post-injury. I didn't put it in the notes. Right, so if something isn't completely healed in 6 to 9 months, we can officially call it a non-union. It has not come together. That fracture should be at least together as one bone and healed at this point.
You just like shave it off and make it like an inch shorter?
Yeah, that's a really good question. I don't know that answer, but Major Davalos will for sure. I stayed out of surgery because that's not for me. Some of y'all here will do great at it. Good grief, it's terrible. I think they would go and they would probably put a rod in here, to be honest with you, to help stabilize it. They're less concerned, if I had to make an educated guess, they're less concerned about this and the shave off than they are the instability of the bone. Right? So they would probably go in, they would probably put a rod in the tibia to help put those two back together, stabilize it, so that way we don't have any issues. This, not really a big deal, unless it's causing them some kind of pain or discomfort. Right? But biggest thing is going to be that 6 to 9 months post-fracture, bone hasn't healed together, we can call it a non-union. This is your malunion. This is healed. But that is not the anatomical position of that radius. That is not what it's supposed to look like. So now what do we do for this? It depends. Is it causing them pain or functional impairment? If it's not, congratulations, you got a funky radius. Enjoy your life. We're going to leave it alone. This is just how you are from now on. But if it's causing functional impairment or pain, ortho will likely go in, re-break it, surgerize it, put it together, and let it try to heal the appropriate way. So that's all going to be patient-related experiences. You'll have some that you leave alone, you'll have some that you'll refer to ortho. But a malunion is any fracture that comes together that is not healed in the anatomic position. We just covered all of those. So which one would this be? Malunion. I'm all one bone. They may be in two different areas, but look, I got cortex connecting these two and bone connecting these two up here. These are all connected. This is all one bone. This is a malunion. This one is likely getting rebroken, surgerized to fix. Because one leg's going to be a lot shorter than the other. Telling the truth. Right? Besides a bad day, I'll just read this one to you to show you how complex some of these descriptions could be. Open, comminuted, mid-shaft tibia fracture with 45 degrees at apex, anterior angulation, and segmental fibula fracture. I am not putting answers like that on the test. I'm not doing that. Right? Good Lord. This is a bad day. What happened here? Anybody know? Anybody guess? Yes. Low velocity gunshot wound. Foreign body stayed right in that tibio-talar joint, caused a comminuted distal tibia fracture, probably talar fracture as well. All this black is going to be that artifact from the bullet that's sitting in there. Questions on how to describe fractures? All right. Take 10 now, come back at 5 till.
I guess unless it's an older book.
Yes. It's no longer
I
type
had
one.
I already knew this.
But once it goes into the metabolism, it becomes type so what that is that is the first part. So really, this one's this part of and you'll see we're gonna get to it in the third picture we took where it shows a pediatric medical program. And you're gonna see the Pisces, it's like a triangular Pisces shape, and you're gonna see what normal is, and then that's gonna go, oh, I get that now. Yeah. Cool. But yeah. Oh yeah, all those non-unions? Yeah, it's just, literally so good. It doesn't hurt, because they got their own policies, right? So like two regular loads now, they got some extra joints.
Like you put it in there and he thinks it's and so like dude, it's disgusting. I love it. Never came together.
Super advanced.
No, they're not. Those are specific. Is university that has a proximate and distal site completely separate from each other. But it's because of they said because of the way it feels like that, like they both draw blood supply, so it's about right. There's got artery got cut, which is crazy.
It was good. It was there's like a delayed opera courses
I think I might have passed it. It's like right where a lot of traffic and construction is.
there's a lot of people walk area really close to the water. Yeah.
But you would still see that it's
Yeah, it was just like
but now it's like a little more you wouldn't see it.
I'm trying to figure out if I'm looking into things too much.
oh, The Witcher. So like it was like the gameplay and they were playing on the background. One lady was like it was really cool. It's got it's really cool.
You'll see on a normal
Yeah,
that's what the shoulder yeah, but I only got a little bit together.
it was cool.
I got that. This one's piece of everything. I mean, there is a connection.
And then I filled out at 5 a.m. on Saturday.
Okay, so the difference in this being is you have a cortex
What's that?
connected versus this one that has the other cortex.
Maybe there's something there, but I can't really tell. And I'm definitely not going to whereas the other one had.
All many words are human else. No.
I think about it. I actually never really look at it. Just for that alone, and football, like, Can I see every
Yeah,
just like it was really, especially out there right now. I'm just trying to play football. get the ice cream towel.
Okay.
Bro, see this?
So 1,500 on the Wednesday, yes, because I still have one Wednesday, and then my mom's on the back, and I'm gonna go yeah, 3103 out. So it's the House of Lords, it's all the SSRC.
Oh, actually, I see every time I came from my house.
Yeah, so just not, yeah, there is, we're talking about. So yeah, so I'm writing down. Try to look at it, right? Try to learn from what I feel like the taxes.
Oh, yeah.
That's the easiest way to learn it. Because the way the lower the salt is, it's confusing. Number two, use the notes wrong. Use the slide when you get to the use that slide, see if it makes sense. If it doesn't, by all means, come to see it.
I guess like you said, he's jumping and fell off.
Well, right, but you did those bid chapters out. Right? So I agree. Distal and mid shaft, which is why mid shaft is not this. I think it's a great idea. Proximal and distal.
Outside of like, just how are you dressing?
Proximal third, distal third, third section. So I recognize that there may be a gray area in some of these. If there's a gray area, one of those.
Like, how cool.
You catch me dry things like once a year, like I have to wear my gaiters. Also, I don't like clothes. Actually, enough clothes that I don't wear. The only thing new is that size. Maybe you wear the I write myself in the ground. I have to have like navigate the
take our seats, let's get going. We got Monday Night Football to watch.
Yeah.
Sir.
Alright?
Stay awake.
Any Ravens Bills fans?
Did you stay awake for that game?
Holy cow. Oh, I'm sorry. I picked the Ravens and I picked them too. Probably the best game I've ever watched in my entire life though. Like, that game was nuts.
Exciting.
Sorry. Ready to go focus now? He's like, can we move on? That's the beauty part about doing this, like, if, like, the Bears get stopped by the Vikings tomorrow, I can just not bring it up and just lecture and just say, shh, we gotta do this. That's okay, I still got the Ravens as my AFC Super Bowl attendee, whatever the heck you wanna call it, they're going this year. Fair. Alright. So we're gonna talk more about abnormalities this one, and we're gonna get down towards the end at the skull and kind of looking at the skull and everything. Now, once we get into spine, we'll do that one pretty slow. Once we get to upper and lower extremity, guys, we go pretty quick through that. Why do we go quick through that? Well, as you've seen, I spent quite a bit of time on a lot of these upper and lower extremity things already, as far as like the posterior fat pad and the elbow and, you know, the dislocations and the avascular necrosis. So really what those other extremity things are is talking about certain dislocations and the names of certain fractures. Like, hey, there it is, we call it this. Questions? No, okay, there it is, we call it this. Questions on that. And then some of it will be reviewed. We'll talk about avascular necrosis again. We'll talk about Salter-Harris again. It'll be a little bit different, we get it longer in these slideshows. So for those that are schedule hawkers and like, oh my gosh, it's getting behind, we're gonna be okay, I promise. Okay. And because I was one of those too, so I know that people in here who are doing that. All right. So, joint disease, arthritises. You can use arthritis to help or you can use x-rays to help diagnose certain arthritises. When you are studying the arthritis section, pay attention to some of the abnormalities on the film, but also pay attention to everything else. Your patient population, your history of injury, your history of pain, what is going on. Because those are going to be context clues to help you sort through it. Because a lot of arthritises can look very similar. Okay? All right. So, we're going to talk about hypertrophic, erosive, and infectious. Hypertrophic, much like our densities, growth of bony areas or radial opaqueness, erosive, decrease, and then infectious is septic arthritis, basically. We'll talk about all those. Radiopedia does have some of these pathologies that you can look at. If you so desire. There is what a normal knee looks like. Okay? Along with the anatomy to show you the synovial fluid, the joint space. You notice how I point cartilage on here? Can't really see the cartilage on the x-ray. It's not going to show up very well. Cartilage is practically invisible on x-ray, excuse me. We would need an MRI for that. But showing you your normal x-ray. MRI or CT? Think about it. MRI. MRI might be, but what other clues are there? Look at all of my cartilage and some of the menisci that I can see. I can see the soft tissue really, really well that I can't make out. On top of that, look at my subcutaneous tissue, how it's bright white and then the muscle is like that darker color. I got the two different colors potentially. In CT, all that soft tissue is just gray. It doesn't have any difference like it does in the MRI. Right? So this is an MRI of the knee, normal anatomy. Not going to make you read an MRI, but you got to know you're looking at an MRI. And what kind of slice is this? Coronals. Good. And here's a closer picture showing you the cartilage, which is the dark area, and the joint fluid, which is the bright white area. Here, fluid, there's cartilage as well, fluid, cartilage. Okay, here's what we're going to cover as far as hypertrophic. Primary and secondary osteoarthritis, pretty much the same thing as far as x-rays go, but it's going to be the patient that's going to tell you which one is which. My favorite, the erosive hypertrophic arthritis. Great, another one of those things where it's kind of both. I'll explain where they got that name and why it's kind of both. Okay. Charcot's we'll talk about, and then we'll look at CPPD briefly, but that is FYI. Arthritis, osteoarthritis, the most common form of arthritis in adults. The most common, okay? Primarily in the hips, knees, and hands. Weight-bearing joints is the most common, so we see it in the hip, knees, and hands. Now, I say weight-bearing joints, right? Can anybody think of a career field where a shoulder might be a weight-bearing joint? Huh? Well, Army, sure. So, yeah, sure, athletes, like maybe a baseball pitcher or something like that, right? Maybe more in our field, mechanics, right? Your airplane or your auto mechanics who are constantly underneath jets and stuff like that, using their shoulders, turning wrenches, using tools, all of that. That can lead to arthritis in the shoulders as well. So don't just marry weight bearing to standing. There are other things, and that's where the hands actually comes in, right? With the mechanics as well too, the hand and the wrist, you can get arthritis in those areas. Most soldiers, unfortunately, and airmen and everybody else are really only doing like the push-ups like once a year or once every 6 months. That's not enough to cause arthritis. ACMT is coming up quick. How much notice do you guys get like here in this program?
It's October sometime.
Okay, so you at least know the month. I know lately, like sometimes they're just like, hey, it's in 2 days. See you at 5 a.m. But I didn't know if you knew the month or like, yeah, that's good. Anyways, okay, so what are some key symptoms with osteoarthritis? Pain is worse later in the day and then better with rest. Well, that makes sense. I wake up in the morning, I haven't been using it yet, it doesn't really hurt. As I'm using the joint, I start to get the pain throughout the day, but then when I rest and I stop using it, the pain kind of goes away. Slowly progressive. Symptoms are uncommon before the age of 40. Uncommon before the age of 40, except in a certain situation which we'll talk about. Typically, bilateral involvement. Okay? Typically, bilateral involvement. This is your primary osteoarthritis. What are we going to see on x-ray? First of all, x-ray is the study of choice. It's also the initial study. It's the only study we're going to do. It is the study of choice. You're going to have osteophytes, which we're going to look at. You're going to get some subchondral sclerosis, which we're going to look at. Narrowing of the joint space, which we're going to look at. But the problem is, all of these things are in all of the arthritises. Right? So that's where I get at the fact that we're going to look at pictures, and there are some of these arthritises that have specific hallmarks that go with it. Like if it looks like this is probably what it is. But in general, you have to use the overall patient concept to figure out what arthritis it is. So, when we are talking about primary arthritis, primary osteoarthritis, hips and knees is what I'm using. All right, now I recognize that it's not super easy to see the joint space narrowing here on the hip, but you can see it here on the knee. Look at the joint space. Now let me go back to my normal knee. Look at the joint spacing there. Never mind the spacing between the two, but look at how it's kind of equal on both sides. It's kind of equal on both sides. Now, when I go to my primary osteoarthritis patient, look at the narrowing that I have. Definitely not equal on both sides. Weight bearing is what tells us this. I also have these extra little kind of radio opaque little guys on the outside here. These are my osteophytes. What this is the body's in constant pain from the arthritis, so it's trying to get rid of some of those pain receptors by building calcium and osteophytes and trying to protect it. When in reality, it just makes the pain even worse because now we're having a more narrow joint. And this is what we talk about when they do x-rays. They go, oh man, that patient's knee, they're bone on bone, right? That's because the joint space is narrowed so much, there almost isn't any, and that tibia and femur are just sitting right on each other. Osteophytes here on the hip as well. Okay. Primary osteoarthritis. Okay? Typically, bilateral involvement, uncommon before 40, so older people, we're all hopefully going to be lucky enough to experience this, because that means we're all around in another 40 or 50 years. In some of y'all cases like 60 or 70. Right? Bilateral, typically, old person, primary osteoarthritis, weight-bearing joints, hips, knees, hands and wrists. Secondary osteoarthritis. Primary means it just happened. Nothing caused it. Just age, life. Secondary, caused by something else. So secondary osteoarthritis, everything else is the same as primary that we just covered, except for usually young people and unilateral, because it's probably caused by trauma. Torn ACL, torn labrum, something that needed surgery, right? A fracture of the humeral head, a fracture of the femoral head, chronic shin splints, right? Consistent rolled ankles, probably causing microfractures or microavulsions, things along those lines. Young person, unilateral, typically post-traumatic, especially if they've had surgery on that joint. They're probably going to get arthritis a lot sooner than anybody else would. A surgery is traumatic, even if it's laparoscopic. A surgery by nature is traumatic to the body. It's invasive, you're cutting things, you're putting screws in things like plates and everything. It's going to cause arthritis at a young age. So, who's at risk of secondary osteoarthritis? Everybody in this room and all the patients you're going to see. So what are my distinguishing factors between, look at the x-ray. It looks almost exactly the same. I have joint space narrowing. I have osteophytes. This one actually has a subchondral cyst in it, this little radiolucent area there, but really focus on the joint spacing and the osteophytes. The x-ray looks exactly the same, which means you can't distinguish between the two with x-ray alone. Who is your patient? What is their history? What is going on? Questions between those two? Okay, draw that line. Draw that line. Young versus old, trauma versus not trauma, unilateral versus bilateral. Erosive hypertrophic arthritis. Most often occurs in which kind of patients? Perimenopausal women. That's another clue. Perimenopausal women. Typically where? The proximal and distal interphalangeal joints, sometimes the first carpal metacarpal joint, and the IP joint of the thumb. What do we get? Severe inflammation and joint pain, and erythema around the affected joint. We didn't talk about erythema at all in my osteoarthritis. So if your physical exam is showing erythema around the affected joint, you can probably rule out your osteoarthritis isn't at this level here. X-ray is your study of choice. You're going to have marked inflammation, joint space narrowing, subchondral sclerosis, and osteophytes. Well, crud, that's all the stuff we just talked about. Thanks for giving me all the exact same X-ray findings that we just talked about. Except this one's going to have erosions centrally located within the joint, which gives you what's called a gull wing deformity. Right here. You can kind of see it here too. Remember when you were little kids and you drew the little picture of the house and the sun, you wanted birdies in the sky? Right there. That's a little birdie you drew when you were like 4 or 5 years old. It's now just in the joint, leading you to erosive hypertrophic arthritis. So that's the key factor on this one. Where was osteoarthritis? It could have been the knees, it could have been the hips, sure, it could have been the hands or the wrists or whatever, but it wasn't in the tippy tip of the fingers. Right? Because technically a perimenopausal woman could have a form of osteoarthritis as well. They fit that category. But erythema around the joint, pain, and then you got these gull wing deformities primarily at the distal and interphalangeal joints. Looks like a little birdie. Alright, here's another picture of it. Look at some of these joints, use your imagination, look at the little gull wing deformities kind of going on here. Now if I were to give this on your test, I'm going to give you a picture similar to this, but I'm also going to give you a vignette to go with it to help you sort through these things. Because all of these things have different style patients, some kind of similar, but has that one or two little things that points you in the most likely direction of where we're trying to get you. And that's really what medicine is. You can be wrong as long as you are the least amount of wrong with the information presented to you, right? You're never gonna go to court and get sued because you made a wrong diagnosis if it was the best diagnosis you could have made with all the information presented to you at the time. Now, if you don't follow up on that and make sure everything's done, that's a whole different story. But that initial diagnosis, you can be wrong. So we're gonna give you everything to point you towards what you think it's going to be. So the goal-weighted deformity, that erosive hypertrophic osteoarthritis. So why is it erosive and hypertrophic? Well, it's hypertrophic because what we're getting here is, look at the radiopaque, look at all the osteophytes that are coming on the edge here, and all the radiopaqueness. But what erodes is the center of that joint space. That's what erodes, which kind of causes it to cave in just a little bit, which is what gives that goal-weighted deformity. It is still a hypertrophic arthritis, there's just a section that starts to erode away, and that's where the erosive comes from. So the diagnosis sounds like an oxymoron, it's really because both are happening at the same time. But the hypertrophy is what stands out more on the x-ray, and then we use that gull-wing deformity in the joint spacing to really kind of give that to us in a perimenopausal woman when you get age rate and you're looking for this most commonly. Okay, moving on. Charcot's, diabetes. Charcot's, diabetes, right? Charcot arthropathy is a disturbed sensation in a neuropathic joint, which is why it's diabetics. I'm going to show you this x-ray in a minute, and you're going to be like, what are you talking about? How is it possible that they are having pain that doesn't look as bad as this x-ray looks like? These x-rays look miserable, but these patients don't feel the pain nearly as bad as the x-ray shows because their joints are neuropathic, because of the diabetes, okay? Typically in the feet and ankles, it can be in the knee as well. Usually it's knee, feet, and ankles, doesn't really go higher than the knee. X-rays are study of choice. Fragmentation of the bone surrounding the joint is a hallmark of the disease. Severe joint degeneration. Listen, I'm going to go over the descriptors, but in reality, we haven't seen anything like this yet. This patient's going to walk into your clinic. That's almost like not even on the tibia, right? That is definitely subluxed off of there. There is no joint space. This is called Charcot's arthropathy. They don't feel, look at how swollen, all that blurriness is because of how swollen the soft tissue is. Right in here. That's why you can't make any of that out. But I mean, look, your fibula is coming down way past here, almost looks like it's into the, tarsals. They should be able to walk. They should not be able to walk like this. But they will walk right into your clinic. Because they don't have any neuropathic pain there because those nerve endings have died off from the years of uncontrolled diabetes. We're seeing this less and less nowadays because people in general, patients are taking their diabetes more seriously. Because at this point they've had colleagues and their friends or family who have died from uncontrolled diabetes, so they do take it a little more seriously, so you don't see it as often, but it is still out there. So that is Charcot's arthropathy. Questions on that one? All right. CPPD, calcium pyrophosphate dihydrate arthropathy. Basically, you're getting the calcium crystals in and around the joint. Usually in the menisci of the knee, you can see it in the wrist too. Pain, erythema, swelling, everything else is the same. X-rays are study of choice. It's hard to distinguish between the secondary osteoarthritis because of the fact that it looks fairly similar. But really, this is FYI, so you won't be tested on it, so it won't be hard for you guys to distinguish on the 22nd. Yeah, 22nd. Right? What you're going to see is linear densities in the cartilage. Now, if you remember up until now, we would do an x-ray, and we couldn't really see the cartilage, right? It's soft tissue, you can't see it. But now you get something that looks like you can see the cartilage. That's not cartilage, those are calcium deposits sitting in the center of the joint. It is never cartilage, You cannot see cartilage on an X-ray. If you see this, it is going to be calcium deposits. Could be confused with gout sometimes, but sometimes it's called pseudo-gout, fake gout. So here's your calcium deposit there. Something you will see again in ortho. It can also be in the wrist, hard to kind of make out there, but really, what you're looking at is the calcium deposits on this one between the lunate and the capitate, the scaphoid, sitting in here. Extra calcium deposits. And then sometimes you'll see these hook-shaped crescents around the heads of the metacarpals. So we just covered hypertrophic, or we didn't cover all of those yet, but hypertrophic, erosive, and infectious kinds. We went over the hypertrophic ones. Questions on the hypertrophic arthritis is how to distinguish one from another. A lot of the x-rays are kind of similar, except for that Charcot's, right? So then it becomes, is there that one thing like the golden uniformity? What is the patient population? What's going on? Everything, use everything I'm giving you to try to paint that picture of what that patient should look like in your head. Let's go into the erosive ones. First one is rheumatoid arthritis. More common in female patients. Doesn't mean it can't be male, more common in female. Great. The erosive hypertrophic one was primarily female, perimenopausal females, right? I don't know why females a lot of the time, it's just what it is. This one is the proximal joints of the hands and wrists. So instead of my distal interphalangeal and my interphalangeal joints, now I'm looking at my proximal interphalangeals, my metacarpal phalangeals, and my carpal metacarpals. So different joints. Can it be in the other ones? Sure. It's just mostly in these ones that are listed here. Bilateral and symmetric, usually. Okay? Early on, just kind of aches, just kind of hurts. But then later on, you get debilitating joint pain and dysfunction of the joints. And you're going to see with the x-rays why it's dysfunction. All right? X-rays, your study of choice. You start seeing erosions of the carpals and the ulnar styloid. Rheumatoid arthritis, as an RA is, they also lead to sclerosis and fusion of certain joints of the cervical spine. We're going to see some pictures here. If I give you an RA question on the test, guys, it's going to be hands and wrists. Okay? Don't get hung up on the RA for the cervical spine, mainly because most of the time that's where patients come in for. That's what you're going to see it as. But what's important is that, I tell you that because if you diagnose it based off of the hands and wrists, and that patient also happens to have cervical spine pain and neck pain, the odds are they have it there as well. Or if they don't, you can counsel them and say, hey, if you start to get neck and cervical spine pain, let us know, we gotta get some x-rays because this can affect that area too. But I won't make you diagnose it off the cervical spine, actually I'll make you do it off the hands. Your late findings, ulnar deviation or subluxation of the fingers at the metacarpal phalangeal joints. Your larger joints don't typically show any erosions or anything along those lines, it's all the small joints. Okay? Here it is in early stage. And you start to see up here in the corner, you start to get these little erosions sitting right in here, is what's starting to happen. And this is right at those MCPs. Okay? This is right at those MCPs. You might have a little bit of osteoporosis going on, kind of hard to tell on this, but you have bilateral and symmetric. See the joints starting to deteriorate. I can't really make out the joint space here. Look at how nice over here I see my joint spaces. Right? My metacarpal phalangeal, I can see the little black line, I can see those joint spaces. I get over here and I can't make those out. Alright? And then it starts to look like this. You end up with ulnar deviation of these metacarpal phalangeal joints. You will diagnose this before you even get the x-ray, because they come in and it is like this. They can't open jars, they can't pick things up and carry it because they just have lost that functionality of this rheumatoid arthritis. Now, good news is, you guys will learn in endo and stuff like that, and ortho a little bit, labs and things along those lines, and clin lab of how to diagnose this based off of symptoms and labs before it gets this bad. But you may end up seeing patients with this. So this is rheumatoid arthritis. What's going on here? Anybody know? So what that is, and bear with me because I can't do it because I don't have rheumatoid arthritis, is the joints are so swollen and eroded that her pinky comes out, the middle phalanx is straight down, and then the distal phalanx is back out. So that is a cross section of the middle phalanx because the joint is so eroded and swollen that when she tries to lay her hand out, it is vertical. And she can't straighten that finger out. And that's what that is. That's what that looks like. That's that cross section of the phalanx. So we have metacarpal, proximal phalanx, distal phalanx, and that's the middle phalanx. That's basically vertical because of the swollen joints. This is very painful. Here's what it looks like from a cervical spine. Alright? More common in the hand, but what we end up seeing is, so you get a little bit of laxity and anterolateral subluxation, but you start seeing kind of like this fusing, really erosions of the joint space of the spinous processes. So we haven't really looked at a whole lot of spine x-rays yet, but look down here. See how you can kind of see the joint spacing of the vertebrae and the spinous processes down here? Right? You see a little bit of joint spacing, but up here it's gone. It's eroded away. These are gonna be the patients that are gonna have a hard time. They can't like bend, it hurts too much to bend forward and look down. This could be one of the reasons why. There are medications that can help with this. This disease is not curable. It's manageable with your DMARDs, which you will learn in pharm, and all that fancy stuff, right? But again, I will give it to you hands if I'm gonna give you a rheumatoid arthritis patient. Questions on rheumatoid? All right. Gout. Hey, look, more common in males. Yes, finally. All right? More common in males. Why? Because the incidence increases based off of diet. What kind of diet? Red meats, alcohol, beans, all of those, all right? Caveman food, right? Where are my keto folks at? Yeah, welcome to Goutland if you continue to do that for the rest of your life. This is so freaking painful. So painful. Most commonly at this joint right here, right? The big toe, the first metatarsal phalangeal joint, swollen, inflamed, erythematous, and severe pain. Right, to the point it says right on there. If they put a thin sheet that touches it when they're having a flare-up, it feels like somebody's stabbing a hot poker through their toe. That's how painful this is. And yet they still don't listen when you tell them what to avoid. I'll just take my meds. Okay. So, gout shows up in there, right? That will erode away that joint a little bit too. Olecranon bursitis can be common, so you'll see that on some patients. Where's that at? Elbow, good. We'll see a picture of what that looks like. And you could end up with some tophi due to the uric acid and the higher cholesterol in patients in that aspect. X-ray is still your study of choice. You don't need an X-ray to diagnose gout. You absolutely do not. This is a clinical diagnosis. You don't need an X-ray. But if you get one, what you may end up seeing is these rat bite kind of lesions across the joint of concern. First of all, you'll see a lot of swelling, which you just saw in the other picture. That's what it's going to look like on X-ray. But then we get these like erosions that are sitting around the edges of the joint at the metatarsophalangeal joint most commonly. And they're called rat bite appearance. A little bit of sclerotic border, but that's the X-ray findings for gout. Again, clinical, not a radiological diagnosis. You do not need X-rays to diagnose this. This is if you see it, you treat it. But that's what it looks like on X-ray. There's the olecranon bursitis. Right? Big swollen olecranon bursa, common. And then your tophi, most commonly in the ears. It can be other areas, but gout most commonly develops these tophi in the ears. Some are painful, some are not. Just all kind of really depends on the patient. Sir?
Is that just the monocytic urate crystals that are in recirculation?
Correct. It's actually a variance of both, so it's mostly the urate crystals that are kind of compiling right there. But because a lot of times these patients have a diet that's high in fatty cholesterol, purine-rich foods anyways, sometimes there's some cholesterol mixed in with that as well. Like, you'll learn like the high cholesterol patients will get like the xanthosmas or whatever in the eyes. Some of that cholesterol sitting in there too, but it's mostly the urate crystals. Which is why depending how they're sitting, how bad it is, some are quite painful and some not so much. Yep. Questions on gout? All right, keto people, throw some carbs in or something, otherwise this is the road you're headed down, don't do it. Okay, psoriatic arthritis. Good Lord, all these arthritises, right? This one doesn't have a gender preference, okay? Seronegative inflammatory arthritis is going to come in handy more when you get into your clean lab and you learn all that stuff more. Oh look, we're back to the small joints in the hands, especially the dip joints. Okay, so now we're back to the dip joints, just like some of the other ones were the dip joints, like the erosive hypertrophic arthritis. So now we got that. This one sometimes can cause the SI joints to have issues as well. We'll look at some pictures of that. 25% of patients develop skin manifestations. What does that mean? What kind of skin manifestations do you think? Psoriasis. Thick, silvery type skin, right? Only 25% though. So do not hang your head on the fact that if the patient does not present with skin issues, then it could not be psoriatic arthritis. That means 3 out of 4 don't have skin issues, okay? But you are gonna have inflammation of the affected joint. You're gonna have pain and sausage fingers and toes. Look and see what that looks like. X-ray is your study of choice. That's pretty much what all the arthritises have been, right? Hallmarks, juxta-articular erosions, especially at the dip joints of the hands. Big fancy words from the picture we're about to see. All right? Let's see. Periosteal reaction along the shafts of the bone is not common. No osteoporosis on X-ray, so you start looking at more osteoporotic things, right? There's a difference between that one versus the erosive rheumatoid arthritis, which can be osteoporotic, but the psoriatic is not osteoporotic. And then also we have this resorption of the terminal phalanges or the pencil in cup deformity. The pencil in cup deformity. What does that look like? So here is my psoriatic arthritis. Most commonly in my dip joints, but it absolutely can be in my interphalangeal joints as well. Okay? Where my joint space at? Where is it at? It's eroding away, right? Look at where, look, here's my normal. I don't got no joint space. Right? This guy can't even straighten out his hands because his is so bad. And I got no joint space. So there's step one. Okay, I got no joint space, it's in there. Alright, I got some erosion starting. Alright, it's in the interphalangeal, the dip joints. What are the ones I know from that? I know psoriatic. Oh yeah, I also know that erosive hypertrophic one. Do I see Siegel deformities? No, not really, I don't. Okay, so maybe it's psoriatic, right? Pencil in the cup deformity. The bone starts to erode from the outer edges, and it looks like the tip of the pencil in the cup. This is the pencil point right there. Pencil in a cup. I didn't make it up. Big smarter people than me did. But this is one of the things, the telescoping of one phalanx into another. That narrowing, that erosion. It's an erosive arthritis. It's eroded it to a point, and it just sits in the base of that other phalanx and looks like a pencil in a cup. That's my psoriatic. Skin manifestation will be helpful. Not always there, but helpful. Here's my sausage fingers. They, no joke, look like little mini sausages. Now, This, look at their fingers, almost the same kind of aspect of the rheumatoid arthritis that we talked about with the joints and the swelling, right? But what's the difference with these guys? These fingers are straight out. The issue is here. They're not ulnar deviated like the rheumatoid arthritis was, where they were shooting out to the ulnar side like this way. These ones are straight up and down, and the issue is that they're more kind of crunched up, and they got those sausage fingers and toes, and they got some pencil in a cup deformities right here starting, right here the thumb, right? Right there, pencil in a cup, kind of starting over here as well. So between the pencil in a cup and the fact that there's no ulnar deviation compared to the rheumatoid arthritis. 25% of patients are also going to have the skin manifestation or the nail pitting, right? The psoriasis nail pitting. You'll learn derm in your senior semester, but again, you're basic enough here to know that. Not guaranteed, but if they have it, that definitely raises psoriatic arthritis on your differential. Questions on psoriatic arthritis? I'm distinguishing it against any of the other ones we talked about, because that's where this gets challenging here, is remembering one of those little nuances for each arthritis, both from a picture standpoint, a radiograph standpoint, but then also a patient presentation standpoint. Okay. Ankylosing spondylitis. Strong association with HLA-B27, you'll learn more about that in the future. Onset between puberty and age 40. Onset between puberty and age 40 is usually when this presents. Can be asymmetric in the SI joints, but in reality, this is low back from back pain. This is a lumbar spine thing. It can affect the SI joints, but lumbar most commonly. What happens is you start to sclerose the vertebrae. Next thing you know, we end up with osteitis, so inflammation of the vertebral margins, bony inflammation. And then the body doesn't like inflammation. Inflammation hurts. You don't want inflammation to happen, so the body starts to calcify. And it starts to try to protect itself. And it ossifies the annulus fibrosus. And you end up getting that classic, what we call bamboo spine. Your spine looks like a big old piece of bamboo that's sitting in the Panda exhibit over at San Diego Zoo. Never been, go sometime, it's great. Or look up bamboo online, I don't know. But you'll see what the picture looks like here. It starts low and progresses up. Over here is other manifestations, and the reason I say that is if you have a patient who has ankylosing spondylitis, they are at other risk of other conditions that are actually more life-threatening. So it's there in your toolbox. Not for me, other classes, but I'd be wrong to talk about AS without mentioning some of these other things. This is what your bamboo spine looks like. It looks like one giant cortex down the anterior portion of the spine. This is the disc space in here, the intervertebral disc space in between each of these vertebrae. But we got this big line that comes right down the anterior side. That is that ossification of that annulus fibrosus. It's connected it all. It looks like a big old piece of bamboo. Now you should have SI joints here too. Moving the pelvis a little bit, I can't really make out my SI joints on this pelvis. They're fused together here. Maybe a little bit right down here, I can kind of see part of that inferior SI joint. But coming up the rest, it almost looks like one giant pelvic bone. Okay, one giant ilius here. But I mean, I can see a little bit of the SI joint down here, but most of that has fused up. So we have bamboo spine with fusion of the SI joints, more common in young males. Again, puberty to 40. Puberty to 40. That's your ankylosing spondylitis. Here's another picture of normal SI joints. Trace them down, here they are. And I know there's some bowel gas in here, but I can't really see these SI joints anywhere. So again, normal SI joints here. But then when I go up here, there are no SI joints at all. On top of that, does anybody see anything else that's fused together? The pubis symphysis, that black dotted arrow. I should have a gap here. I don't. That pubic symphysis has also fused together due to the ankylosing spondylitis. And then I'm starting to have some erosions of the pubic rami, the ischium right down here. That's what the white arrow is. Does everybody see the ankylosing spondylitis? Understanding kind of how that works and what that looks like. Bamboo spine, fused SI joints, probably fused pubic symphysis, fused U40, back pain. Okay, I need some to reconcile. I know it's late. Infectious. Infectious. So, we have two types, right? So whether it's a hematogenous spread of an infected source somewhere in the body. Could be direct, maybe indirect. Doesn't really matter, we got an infected joint. It's pyogenic, Staph aureus is the primary cause. Non-pyogenic, mycobacterial tuberculosis is the most common cause. Or it's the most common cause of that, that's the most common in thoracic spine. I am not here in this block to test you on bugs. Okay? Why is this here? Man, I got this patient with cystic arthritis. You know what? What antibiotics should I give? I remember that joker standing up there in X-ray giving me this slide that told me the most common cause. Let me see if I can go back to it real quick so I know what to treat it for. Right? Or you can use up to date. It's probably easier. You're probably not going to see these slides, but it's there for you. I can sleep well at night knowing I armed you with knowledge. So, but I am not going to get you with the bugs for the septic arthritis. That will change a little bit in your pneumonia in block 2, because that is pretty important, but just that's there for you. Tends to be monoarticular. Well, why is it monoarticular? Well, much like my secondary osteoarthritis, it's the joint in question. It's the joint that's injured. It's the joint that has the infection. Not going to have that kind of everywhere. It's going to be wherever that took hold, right? Adults most commonly in the knee, children in the hip, hands, due to human bites. Who's running around biting people? Kids, crazies. Somebody said it. Fight bite. Anybody know what fight bite is besides the one who said fight bite? Yes. Got into a fight, punched somebody, hit him in the tooth, broke the skin. That's a human bite. If that doesn't get treated with antibiotics, that will likely get infected and can lead to an infectious arthritis. Even though they didn't get bit, it often gets overlooked because there's other scrapes and stuff from the fight. So you have to actually ask them, like, did you punch somebody in the face? They're gonna be, well, I didn't do that. I want to get in trouble first sergeant. I need to know so that way I can treat you appropriately. I'm not going to tell first sergeant what you did. We have patient-provider confidentiality. Did you punch somebody in the face? Yeah. Okay. Antibiotics for human bites. Right? And then feet, diabetes. What? How do I get infectious arthritis from diabetes? The ulcers, like we talked about before. Take off their damn shoes and socks and look at the bottom of their feet. Because this will lead to an infectious arthritis. Or now, don't shake your head, don't do it. Otherwise, I won't be sitting in the jury and be like, no, I told him to do it. You know? Take away his license.
That's the people who are
You better look yourself too. So what happens? So you get rapid destruction of the joint, right? We talk about all these other arthritises, they're slow rolling. They're not fine this week and then next week or 2 weeks now they roll in and they got Charcot's, right? It doesn't happen that quick. It's a slow roll. This, the pyogenic, is quick and painful, okay? The non-pyogenic, it takes a little bit longer. It's a gradual loss. Biggest thing here, right, different from all the other arthritises. X-ray's your initial study, but look at your study of choice. MRI is your study of choice. Why? Because again, I have that infection now of this synovial fluid, right? I want to see how, I want to verify that infection and how widespread it is. So I'm now looking for infection or inflammation in that synovial fluid as opposed to just looking at the bony abnormalities. You still get the x-ray, because the patient presentation in the x-ray is gonna what's leads you to believe that this could be a septic arthritis. And then your MRI can be your study of choice if you wanna verify it, alright? One of the hallmarks of pyogenic, destruction of the long segments of the articular cortex is really rapid, we're gonna look at some of these. And then non-pyogenic is gonna be your severe osteoporosis over a protracted course or a longer course. Indirect or direct? Indirect is gonna be a blood infection that settles the joint. Direct is what we talked about, bite by some type of broken skin, right? That open fracture that, whoops, we forgot to treat appropriately, and now we have a septic arthritis, all right? Risk factors are right here. Risk factors are wonderful things to put in patient vignettes, because it gets you to go, oh, if you have a history of this, now all of a sudden something else may raise on my differential based off of what I'm thinking about when I go to look at the picture. IV drug use, IV or oral steroids. Why drug use? Right? Open into the bloodstream, can get infected, can introduce bacteria that way, especially not using clean needles. Steroids, IV or oral, steroids decrease our immune system, right? They're anti-inflammatory, so they calm our immune system down, makes us more susceptible to infection. Joint prosthesis, trauma, or surgery. Again, open to the outside world. Open to the outside world, cause bleeding and stuff in that area when we were fixing it from a surgical standpoint, or if I put a prosthesis in. If that prosthesis was not sterile when it went in, I can end up with a septic arthritis. And then immunocompromised, same concept as the steroids, right? The immune system is down. So those are really good risk factors to kind of raise some of these things to your high differential. And then look at what it's doing. It's starting to erode the bone around it, and in some cases, completely erode the bone, right? This is severely painful. It starts off as the infection, right? And then it turns into a septic arthritis. Now, I get this question often. You can start with an osteomyelitis and then have it turn into a septic arthritis if it continues to go untreated. They're very similar in nature, which means I'm not going to give you both as a question answer for something like this because of how similar they are. Because what stage is it in myelitis versus arthritis? Right? Chicken before the egg, it just all depends on what the reasoning for the infection came in from. Right? If I give you the IV drug use and it's an indirect spread from the blood, well, that's not going to be an osteomyelitis. That would have gotten to the joint first and you just would have had the septic arthritis. But if we're talking about a joint surgery or a prosthesis or an open fracture, what came first, the chicken or the egg? I don't know. Bottom line is going to cause the same issue. Either the erosion of the bone or the erosion of the joint is going to happen, osteomyelitis or septic arthritis. Okay. Again, most common for your pyogenic, infectious, rapid loss of joint space, monoarticular, Staph aureus, and gonococcus. I'm not going to quiz you on blood, but I'm coming in later. Just give you an example of what that looks like. What did I say for that black arrow? Okay. The black arrow is just meant to show you what the articular cortex is supposed to look like compared to the one that's eroding away. Just wanted to make sure there wasn't some small abnormality there. So this is my normal compared to what's happening here. Not that you need that on this one, but you know. Non-pyogenic, usually mycobacterial tuberculosis, gradual loss of joint space, monoarticular, okay? But you can see this one doesn't look nearly as severe as this one does. It's much gradual, much more gradual. Still a septic arthritis or infectious arthritis. So for the non-pyogenic, adults most commonly knee, children most commonly spine. We just talked about those. Pyogenic and non-pyogenic. And because the next section is completely FYI, we're going to go real quick through it, and then we're going to call it, right? Not going to belabor a lot of this. This is FYI because you are gonna see bone lesions in your clinic, and you're going to see things in HEMONC and other places. So this is meant just to expose you real quick. I'm not testing you on bone lesions, okay? I'm not, but you will see it in other classes. So this chart will benefit you, especially in the peds. Certain bone lesions and certain ages match up really nicely. Peruse that at your leisure. Here is a rudimentary 5-year-old drawing of the different shapes of different things of the different bone lesions. Primarily, the biggest thing that's going to benefit you guys is under 30 versus over 30, to give you an idea of what you might be looking at. Notice how there's a lot less over 30, because children are complicated. Most common areas of different things. Most common areas of different things. Okay, osteoid osteoma. Nice little radiolucent thing in the cortex of the bone. Probably not that big of a concern. Why? It's well defined, I can see it. Probably not a bad guy. Nothing I need to be overly concerned about compared to, let's go take this off. Osteochondroma, basically a growth off the bone. What am I gonna do for this? Depends. Is it painful? Probably is. Usually it comes up in, is this peds or adults? Peds, look at those spices, right? Usually it comes up in kids, usually they come in because it's painful. They'll go in, ortho will take care of it. But there's the osteochondroma. It's basically just off of the side of the bone, it's actual little growth. Fibrous dysplasia. It's the fibrous area of the tissue on the tibia, again, typically in pediatrics. So everything in bone lesions, even though it's not on each particular slide, is FYI. I'm not testing you on bone lesions. Say it again. Then you get into the scary crap. May not know what it is, but your pucker factor should go up, and you're gonna be calling RADs and probably oncology right afterwards, because that's an osteosarcoma. That is not a good thing. Complete destruction of the cortex of the affected bone. 3 is a scarring lesion or bone lesion, right? Same thing with everything else. Well-defined, ill-defined, or with bones, we can use sclerotic, right? Scarring, sclerosis, like we talked about some of the AVN. And then the location, no different than the other bones. The nice part about this is in peds, you can also use metaphysis or epiphysis as well when describing that. Yeah, blah, blah. Okay. Questions? Again, bone lesions not testable, okay? But those other slides, those 3 main slides there, are very beneficial for you in phase 2 and in your clinics when you get there. I will hang out for a